Welcome back to Uncovering Bailey in Love with Snazzy Surgeon. Today, we're going deep into the decisions we make when we're, managing early stage breast cancer.
Okay.
So we're talking, stages 0, 1, and 2. And as we know, there are two fundamental areas that are going to, drive our treatment decisions and the ultimate outcome for the patient.
Right.
And that is, addressing the tumor itself,
Yes,
and then also meticulously addressing the axilla.
absolutely. And I think, in these early stages, we have a spectrum of options, a spectrum of treatment options. So the art really lies in tailoring our approach to each individual patient and the nuances of their particular presentation and disease.
Okay, so let's start off by just talking about addressing the tumor itself.
Okay.
So, surgically speaking, there's two main strategies that we're going to think about.
Yeah.
And that's going to be, mastectomy versus breast conservation surgery, or BCS.
Right.
So, what are some of the situations where you would, think about mastectomy as your primary treatment?
Yeah. So I think there's a few things that immediately come to mind. I think one would be, a significant tumor burden relative to the size of the breast.
Right.
So, achieving good margins with conservation can be technically challenging and often lead to a suboptimal cosmetic outcome.
Yep.
So, in those situations, that's one thing to think about. Another thing would be multicentric disease.
Yep.
So if there are multiple distinct tumor foci in, different quadrants of the breast,
Okay.
that again would favor a mastectomy. Then we also think about the, diffuse microcalcifications that we see on mammograms.
Right.
Those often correlate with extensive DCIS throughout the breast. So, that generally, again, necessitates, complete removal.
Okay. So, we often also think about, patients' genetic predisposition to developing breast cancer.
Sure.
So how does that play into our decision-making as well?
Yeah, it's crucial. So, patients who harbor BRCA1 or 2 mutations, we know that they have an elevated lifetime risk of both, ipsilateral and contralateral breast cancers.
Right.
So mastectomy, often bilateral, emerges as a really significant risk-reducing strategy.
Right.
So that's definitely something that we discuss with these patients. Another thing we would think about would be a, local recurrence. So if a patient had previous breast conservation surgery, radiation, and then has a local recurrence,
Okay.
then, in those cases, a mastectomy is generally the preferred, and often only surgical option.
Right.
And then I think last but certainly not least is patient preference.
Okay.
Some women may elect for mastectomy, for a variety of personal reasons or perceptions of risk.
Sure.
Even if they meet the technical criteria for BCS.
Right. So, once we've made the decision to do a mastectomy, there's different types of mastectomies.
Yeah.
Can you walk us through, the different approaches that we have available to us?
Yeah. So the traditional mastectomy involves the complete removal of all breast tissue.
Okay.
And that includes the skin directly overlying the tumor, the nipple areola complex, and then the axillary tail.
Okay.
So that superior lateral extension of breast tissue toward the axilla.
Okay.
And the surgical boundaries, are fairly well defined.
Yeah.
So, superiorly, we go to the level of the second rib, medially to the peristernal edge, inferiorly to the inframammary crease, and then laterally to the anterior border of the latissimus dorsi muscle.
Okay. So what about a radical mastectomy, the Halsted procedure?
Yeah, so I think, thankfully we don't really encounter that too often in modern practice.
Right.
Historically that involved block removal of the breast, all 3 levels of axillary lymph nodes, and then both the pectoralis major and minor muscles. And the reason we really don't do it anymore is because of the, fairly significant morbidity that's associated with it.
Right.
So, limitations in shoulder movement, lymphedema, pain, chest wall deformities.
Right.
So, I think really it's become sort of a historical footnote,
Right.
With our understanding of disease progression, and as less radical but equally effective techniques have evolved.
So the approach that we typically use now is the modified radical mastectomy, or MRM.
Right, exactly. So that combines complete removal of the breast parenchyma, similar to the traditional mastectomy, but then with the addition of a comprehensive axillary lymph node dissection.
Okay.
And that encompasses levels 1, 2, and 3.
Okay.
And there's some technical variations of the MRM that relate to how the pectoralis minor muscle is managed.
Right.
So, in the Pat-Tier-Madden modification, the pec minor muscle is resected.
Okay.
In the Auchincloss technique, it's retracted. And then in the Scanlon approach, it's divided.
Okay. But it's left attached at its origin and insertion.
Okay.
So those are just kind of technical nuances that often reflect, the surgeon's preference or anticipated extent of disease.
Okay. And then, nowadays we're also thinking about preserving the skin envelope, right?
Absolutely.
And that's particularly in the setting of reconstruction.
Right, yeah. So, a skin-sparing mastectomy is a technique where we preserve the majority of the breast skin.
Okay.
But we still remove the nipple areola complex.
Okay.
And that's particularly advantageous, when immediate breast reconstruction is planned.
Right.
Because that intact skin envelope allows for a more natural breast contour.
Right.
And then we can even do a skin and nipple areola sparing mastectomy.
Okay.
In carefully selected cases.
Okay.
This would be for DCIS or early stage invasive cancers where the tumor meets certain distance criteria.
Okay.
And those criteria are generally the tumor needs to be more than 1 centimeter away from the skin surface.
And more than 2 centimeters away from the nipple areola complex.
Okay.
So these techniques really aim to maximize the aesthetic outcome following reconstruction, but without compromising oncologic safety.
Right.
And then speaking of, reconstruction, there are a wide variety of options available.
Right.
Ranging from autologous tissue flaps and fat grafting all the way to silicone implants.
Right.
And these are things that, we discuss with the patient in detail as part of the overall surgical plan.
Okay. So now let's move on to breast conservation surgery, or BCS.
Okay.
And I guess, what's the fundamental oncologic principle when we're thinking about this approach?
Yeah, so I think the fundamental principle of BCS is complete surgical excision of the tumor.
Okay.
With a minimum 1 centimeter margin of surrounding normal breast tissue.
Okay.
And this is often referred to as a wide local excision or lumpectomy.
Right.
But it's critical to understand that, BCS, to achieve oncologic equivalence to mastectomy, must almost always be followed by adjuvant radiotherapy to the remaining breast tissue.
Right.
So that combination is termed breast conservation therapy, or BCT.
Okay.
And that radiation component is non-negotiable for optimal local control.
Okay. So margin assessment is obviously, critical when we're doing a BCS.
Yes.
So, what are some things that we do in the OR to make sure that we have that 1 centimeter clear margin?
So precise specimen orientation at the time of surgery is really vital.
Okay.
So we typically use sutures to mark the surgical specimen.
Okay.
So we'll put, typically a long suture laterally. We call that the L suture.
Okay.
And then a short suture superiorly, and that's the S suture.
Got it.
And this allows the pathologist to accurately assess all the resection margins and identify the precise location of, any margin that may be positive.
Mm-hmm.
And, if the initial path reveals a positive margin, then, the standard approach is to perform a cavity shave, which involves re-excising additional tissue.
Got it.
Specifically from the area of the involved margin.
So are there any times when you wouldn't do a BCS? So what are the contraindications to doing a BCS?
Yeah, there are several contraindications. So one, we talked about multicentric tumors within the breast, so that would preclude BCS. Similarly, diffuse microcalcifications spanning a significant area of the breast is generally a contraindication.
Okay.
A large tumor burden in a relatively small breast, so a high tumor to breast ratio often makes it technically impossible to achieve both adequate margins and a satisfactory cosmetic outcome.
Right.
If we've performed 2 or more re-excisions for positive margins and still haven't achieved clear margins, then I think, at that point, proceeding with mastectomy is more prudent.
Okay.
Prior radiation to the breast or chest wall is a contraindication.
Right.
Because of the potential for overlapping radiation fields and increased risk of radiation-induced complications.
Okay.
And then, certain underlying connective tissue diseases, such as lupus or other collagen vascular diseases, are relative contraindications.
Right.
Due to an increased risk of, severe adverse reaction to radiation therapy.
Right.
And then, in practical terms, conditions like ankylosing spondylitis, which can limit a patient's ability to position for radiation treatment, and severe orthopnea, where the patient can't lie flat, can also make BCS and subsequent radiotherapy very challenging.
Right. Right. Absolutely. And now let's get into the area of oncoplastic techniques.
Yeah.
And this is really the marriage of, oncologic surgery and plastic surgery.
Right. Right. So oncoplastic surgery aims to really integrate sound oncologic resection principles, but with the addition of plastic surgery techniques
Right.
to achieve optimal cancer removal, but with improved aesthetic outcomes. So a standard wide local excision where we remove up to about 20% of the breast volume can often be closed primarily using absorbable sutures,
Okay.
and that results in an okay cosmetic result.
Okay.
True oncoplasty involved, a more extensive excision
Okay.
with a formal reconstruction of the surgical defect.
Okay.
And we categorize those into different levels.
Okay.
So level 1, or volume displacement techniques, involve the mobilization and rearrangement of existing breast tissue.
Okay.
So a common example of that is dual plane mobilization,
Okay.
where we might dissect and advance the dermoglandular flap while also working in the pectoralis plane
Okay.
to redistribute volume.
Okay.
Level 2, or volume replacement techniques, are employed for larger defects, typically exceeding 20% of the breast volume.
Okay.
And that often necessitates the use of local tissue flaps or even distant pediculed or free flaps
Okay.
to adequately fill the void. And then, finally, quadrantectomy, as the name implies, involves removing an entire quadrant of the breast that contains the tumor.
Okay.
This is, a more significant resection, but it can still be considered a breast-conserving approach
Okay.
when followed by irradiation.
Okay.
Yeah.
Great. So, we've talked about the tumor itself and how we're going to address the tumor itself.
Yep.
But, the other part of treating breast cancer is addressing the axilla.
Yeah.
So, our two main surgical approaches, are going to be sentinel lymph node biopsy, or SLNB,
Right.
and axillary lymph node dissection, or ALND.
Right.
So, let's start by talking about SLNB.
Okay.
And, what's its primary role in our management algorithm?
Yeah. So the primary role of sentinel lymph node biopsy is accurate staging of the axilla.
Okay.
And this is in clinically node-negative patients.
Right.
And the idea is if we can identify the first lymph node or nodes in the lymphatic drainage pathway, from the primary breast tumor, if those nodes are free of disease, then we can avoid a full axillary node dissection.
Right.
Which we know carries a higher risk of, morbidity, such as lymphedema.
Okay. So how do we actually go about finding these sentinel lymph nodes in the operating room? What are the different tracers and techniques that we use?
Yeah, so we use a combination of different tracers.
Okay.
So blue dyes like methylene blue or patent blue are commonly injected.
Okay.
We also use radioisotopes, so technetium 99 meter labeled albumin or sulfur colloid,
Okay.
which are also injected. And then more recently, fluorescent dyes like fluorescein or indocyanine green
Okay.
have been incorporated into practice.
Okay.
And the injection site can vary depending on, surgeon preference and tumor location.
Okay.
We might inject peritumorally, perioral, subariolarly,
Right.
or even intradermally.
Okay.
And then in the operating room, we use, several methods to detect the sentinel nodes. So visual identification of any blue-stained lymph nodes, a handheld gamma probe to detect what we call the hot nodes, so the nodes that have accumulated the radioactive tracer,
Right.
and then specialized cameras for fluorescence imaging when using dyes like indocyanine green.
Okay, great. And so, once we've taken these sentinel lymph nodes out, what are the next steps in determining whether or not they have any metastatic disease?
Right. So there are, criteria that guide which nodes we prioritize for removal.
Okay.
So typically any lymph node exhibiting more than 10% of the ex vivo radioactivity count of the hottest node,
Okay.
as well as any nodes that are, visually stained blue or
Yes.
fluorescent.
Right.
And then those nodes undergo pathologic evaluation.
Mm-hmm.
We often use frozen section analysis intraoperatively, which allows for rapid preliminary assessment.
Okay.
But, it's important to remember that, frozen section does have a false negative rate.
Right.
That's in the range of 10 to 12%.
Okay.
Touch imprint cytology is another rapid technique that can provide immediate information.
Okay.
And then, increasingly we're also using molecular assays such as the GeneSearch breast lymph node assay,
Okay.
which can, offer more sensitive and specific detection
Okay.
of, even small volume metastasis.
So are there certain times when we wouldn't want to do a sentinel lymph node biopsy or when it's considered to be unreliable?
Yeah, there are some contraindications to SLNB. So in the setting of inflammatory breast cancer,
Okay.
the lymphatic drainage patterns are often, disrupted and unpredictable,
Okay.
making, SLNB unreliable.
Got it.
Similarly, in patients with T4 disease, which signifies a more locally advanced tumor,
Okay.
with a higher likelihood of extensive nodal involvement, SLNB is generally not recommended.
Okay.
If a patient has undergone prior surgery or radiotherapy to the breast or chest wall, again, the lymphatic pathways may be altered or disrupted.
Right.
So that can compromise the accuracy.
Got it.
And then significant breast scarring from prior burns or other extensive surgical procedures can also interfere with lymphatic drainage.
Okay.
And it's typically considered a contraindication.
So when do we do an axillary lymph node dissection, or ALND?
Yeah, so the clear indications for proceeding directly to an ALND are when a patient presents with, clinically palpable axillary lymph nodes
Okay.
that are suspicious for metastasis, or when there's a cytologic or histologic confirmation of axillary lymph node metastasis,
Right.
prior to definitive surgical treatment.
Right.
And then if the sentinel lymph node biopsy reveals, 3 or more positive sentinel nodes containing macrometastasis,
Okay.
a complete ALND is usually recommended.
Okay. So what does an axillary lymph node dissection actually involve?
Yeah, so the standard ALND procedure involves, meticulous surgical removal of level 1 and level 2 axillary lymph nodes.
Okay.
We consider extending the dissection to include level 3 nodes if there's, clinical or intraoperative evidence of enlarged or matted lower level nodes,
Yep.
which suggest involvement in the apical axilla.
Okay.
And throughout the dissection, it's critical to identify and preserve, a number of critical neurovascular structures
Right.
to minimize postoperative morbidity.
Right.
So, those include the axillary vein, the thoracodorsal vessels,
Okay.
the medial and lateral pectoral nerves, which innervate the pec muscles, the intercostobrachial nerves, which provide sensation to the upper inner arm,
Okay.
and then the long thoracic and thoracodorsal nerves, which innervate the serratus anterior and latissimus dorsi muscles.
Okay.
So injury to these nerves, can lead to significant functional deficits and long-term complications.
You mentioned preserving the intercostobrachial nerves.
Mhm.
Are there situations where we would need to sacrifice those nerves?
Yeah. Unfortunately, in cases with a really high burden of disease in the axilla,
Oh, yeah?
with significant extracapsular extension and involvement of the surrounding adipose and connective tissues,
Right.
we may need to divide one or more branches of the intercostobrachial nerve to achieve, adequate oncologic clearance.
Okay.
This can unfortunately result in, permanent numbness in the upper inner aspect of the arm.
Right.
But in the context of, achieving regional disease control,
Right.
it can sometimes represent a necessary trade-off.
Yeah. So we've covered, a lot of information today, really about, the key surgical principles when managing early stage breast cancer. And I think it's pretty clear that, the decisions surrounding the local treatment of the tumor and the regional management of the axilla are really, multifaceted.
Yeah.
And it really requires us to think about a lot of different factors, patient factors, tumor characteristics, the risks and benefits of each approach.
Absolutely. Yeah, it's a continuous exercise in clinical judgment, trying to balance the need to achieve optimal oncologic outcomes,
Right.
but also trying to minimize morbidity
Right.
and maximize quality of life after treatment.
Right. Well, this was a great discussion. I really appreciate you, going through all of this with us.
My pleasure.
And to all of our listeners out there, thank you for listening to our podcast. See you in the next episode.